All right, everyone. You know how every summer and fall we start seeing those familiar peaks in the lab? Well, Coxsackievirus A and B are always on that list. So, in this explainer, we're going to do a focused dive into these viruses, specifically from our Dutch clinical perspective. We'll cover the virology, the diagnostics, and, the really crucial role that we play in managing these infections.
And just a quick heads up before we jump in. All the information we're about to go through, it was put together using a Gemini deep search. We pulled from key Dutch clinical guidelines, RIVM directives, all that important stuff. If you want to dig deeper into the data yourself, the full list of sources is right there in the linked Notebook LM document. Okay, so here's our game plan. First, we're going to get to know the virus itself, this formidable, shape-shifting bug and the clinical chaos it can cause. Then we'll look at how our diagnostic tools have evolved, from viral culture to molecular code. After that, we'll really focus on the clinical impact our labs have, especially when there are no treatments. And to wrap it up, we'll look at the uniquely pragmatic Dutch approach to infection control.
So, let's start at the beginning, with the virus itself. It's a really resilient pathogen, and it's known for causing just a dizzying array of clinical syndromes, which, as you know, is exactly why our work in the lab is so essential. Starting with the basics, the taxonomy. Coxsackieviruses are part of the Picornaviridae family. But honestly, the most important word on this slide, for us, for practical purposes, is naked. Because they don't have that lipid envelope, these viruses are incredibly stable out in the environment, and, this is the key part, they're resistant to our standard alcohol-based disinfectants. This is a critical piece of information that we're often relaying to our infection control colleagues.
Now, this classic division into Group A and Group B, it feels a bit old school, doesn't it? I mean, it's based on what the virus does to suckling mice. But here's the thing, it is still incredibly relevant. The Group A serotypes, they cause this widespread muscle necrosis and flaccid paralysis in mice, which perfectly mirrors their tendency to cause those mucocutaneous diseases in humans, like hand, foot, and mouth disease. And then on the other side, you've got Group B. They cause specific organ damage in mice, which predicts their preference for deeper, visceral diseases in humans. We're talking myopericarditis and pancreatitis. So yeah, this historical grouping, it's still a surprisingly powerful clinical clue.
And this table just brilliantly illustrates the central challenge we face, right? The one virus, many diseases paradigm. You can see right here how a single syndrome, let's say aseptic meningitis, can be caused by a whole bunch of different serotypes from both Group A and Group B. And then you flip it around, and a virus like Coxsackievirus B5 can show up as anything from a mild case of hand, foot, and mouth to severe life-threatening myopericarditis. This massive clinical overlap makes a diagnosis based on symptoms alone pretty much impossible, which just reinforces how indispensable the lab really is.
Okay, let's move into our domain, the lab. Our ability to diagnose these infections has been completely transformed. We've gone from the slow, painstaking work of viral culture to the incredible speed and precision of reading molecular code.
This table, honestly, it tells the whole story. Viral culture, it was once the gold standard, but now it's basically history. The turnaround time of days, sometimes weeks, and its poor sensitivity for a lot of the Group A viruses make it useless for managing an acute patient. Serology? That just tells you what happened in the past. So the crucial point here is that pan-enterovirus RT-PCR is the undisputed champion. A turnaround time of just hours, super high sensitivity, it is the cornerstone of diagnosis in every single Dutch hospital today.
And this has led to a really effective standardized workflow here in the Netherlands. Step 1 is simple. We run a pan-enterovirus RT-PCR, usually on a CSF sample, as part of a meningitis panel. Step 2, the second we get a positive result, we communicate it immediately to the clinician because it has direct management implications. And then step 3, for the really severe cases or for public health surveillance, the sample gets sent over to the RIVM for VP1 sequencing. That gives us the precise genotype, which is just critical for surveillance.
This brings us to what I think is the most important part of our job. In a situation where there's a complete lack of specific treatments, a therapeutic void, our diagnostic work isn't just about naming a bug. It's a direct clinical intervention. It guides therapy, and it promotes stewardship.
And let's be crystal clear on this point. There are 0 approved, licensed antiviral agents for Coxsackievirus infections. Not here, not anywhere. Some of the investigational drugs you might remember, plecanaril, they just never made it to market. This single fact elevates the importance of everything else we do, from the diagnosis to supportive care.
So with no specific antivirals, management is all about supportive care, and our national guidelines are very straightforward. The NHG standard points to paracetamol for pain and fever. Hydration is absolutely key, especially for kids, since those painful oral ulcers are the #1 reason they get hospitalized. And it's also worth noting that the RVM-LCI RIC line specifically cautions against using oral lidocaine, which is a little different from what you might see in some other countries.
So here it is, the take-home message. Our diagnosis is the main event. A positive enterovirus PCR from a sterile site like CSF is one of the most powerful tools a clinician has for antimicrobial stewardship. It provides that objective, black and white evidence they need to confidently stop empirical antibiotics. This is a core goal of national programs like SWAB, and this is our direct impact.
And nowhere is this impact more critical than in the neonatal unit. Severe neonatal Coxsackievirus B infection looks exactly like bacterial sepsis. The NVK guidelines rightly mandate immediate empirical antibiotics. You have to. So in this incredibly high-stakes scenario, our rapid PCR result is the single piece of data that allows the neonatologist to safely de-escalate, to stop those broad-spectrum antibiotics and avoid all the risks that come with them. It is a textbook example of diagnostics-driven care.
Okay, finally, let's talk about prevention. The Dutch approach to infection control for Coxsackieviruses is a really fascinating case study in pragmatism. We have very different strategies for what happens out in the community versus inside the hospital.
And what's so interesting here is the contrast. Out in the community, the RIVM guideline is super pragmatic. It says that kids with hand, foot, and mouth disease don't need to be excluded from daycare, basically because containment just isn't realistic. But the second you step inside the hospital, the goal shifts completely. It's all about preventing transmission to vulnerable patients. And that's why we use stringent contact precautions and full PPE. It's not a contradiction, it's just a really smart, risk-based policy.
So, to wrap it all up, our role in managing Coxsackievirus is just absolutely vital. We're the ones who provide that diagnostic clarity in what can be a really confusing clinical picture. And that clarity, that's what guides patient care, that's what enables good antimicrobial stewardship, and that's what supports our national public health surveillance. And that leaves us with a forward-looking question, something to think about. We are generating a huge amount of genomic data through all this surveillance sequencing, so the next frontier has to be this. How can we move beyond just identifying the virus to actually using that genomic data to predict which patients are at the highest risk for severe disease, even when we can't treat the virus itself?
And that's it for this explainer. I'd love to hear what you think about that final question down in the comments. And of course, be sure to subscribe for more deep dives into clinically relevant microbiology. Thanks for watching.